Hi, good evening, everyone. Thank you for taking time out of your day. This is a passion of mine, and so it's a delight and an honor to be able to participate and to work with other empathetic doctors treating patients who need a lot of empathy. Many of whom have unfortunately been gaslit by their doctors and their families, even for problems that were previously pretty inexplicable. And so I've known patients who've come into my office and I've asked them about a symptom and they'll tell me, "Oh, I wasn't going to talk about that. All my doctors and family tell me not to even bring this up with you." And so this is a passion of mine. I always want to make sure I treat my patients the way I would personally want to be treated under the circumstances. So anyway, I'm Dr. Arthur Jenkins. Some of you in the audience may know me. Some may not. I'm a neurosurgeon by training, spine surgeon by specialist, a researcher by passion, father of three. I do what I do because I always want to make sure if the situation were reversed, I'd be equally happy with the outcome of whatever conversation, procedure, or whatever we're doing. Um, and so I had not known anything about this during my residency. It was not on boards in any meaningful way. And I started having patients that would come into my office that were a real mystery. Fortunately, I like mysteries. A little background, it's a standard practice to describe your disclosures prior to beginning any meaningful talk. And so I am a spine surgeon. I do make money doing spine surgery. I think I do it pretty well. I'm also an investor in a couple of companies. I have my own company to try to prevent injuries and to help with surgical techniques, but I have no revenue from that yet. Concepts: be patient, be persistent, and be pragmatic. We can get you to a better place. As we've heard earlier, hypermobility syndromes, including Ehlers-Danlos syndrome and others, including potential post-infectious syndromes, do damage the ligaments, the underlying stability of what holds the bones of the body together. And in particular, the upper cervical spine, where the head meets the spine, is one of the areas where we have some severe symptoms. But patients don't walk in and say, I'm suffering from craniocervical instability. That'd be an odd conversation to have. But they do talk about their brain fog, their headache, their passing out when they're standing up, or maybe not. Some of their seemingly unrelated or unexplainable symptoms that can be quite disabling. And in fact, in many cases, they're afraid to even bring some of the more disabling symptoms up, not just postural orthostatic tachycardia syndrome and the feeling like you're going to pass out when you stand up, but even sexual dysfunction, gastrointestinal dysfunction, urinary dysfunction, things that they can't explain. Nobody else can see anything on the standard MRI images, and they're just afraid of not being taken seriously. But if you know what questions to ask, they're usually more than happy to describe them. The fundamental anatomy has been reviewed already, but I think it bears a little bit of discussion because we're going to be discussing treatments that are specific to this area. And of course, the spine sits at the bottom of the skull. The spinal cord moves out through the middle of the spine and the middle of the bottom hole of the skull. And nerves, blood vessels travel through the skull to then travel within the neck, in and outside of the spine. And excess movement can put traction and pressure on these structures that live in this area, including the arteries, the veins, and the nerves that run in these areas. Now, the sympathetic trunk happens to be one area that seems to be very poorly understood, but everybody has one, and you need that balance. And that runs right up on the outside edge of the spine and goes up into ultimately terminates in smaller nerves that go into the brain. And then in addition to that, there are ligaments that hold the spine together and they move in different angles depending upon where they are. And there are some ligaments that are actually especially suspect in patients with conditions like Ehlers-Danlos syndrome, or patients who have had trauma that has put excessive rotational stress on the spine. Some of these what normally are considered minor ligaments may be ruptured, and that may leave the head still attached but allow for excessive range of motion. But it's not a problem because you want to be more stable rather than completely unstable. The head falling apart is not a good thing. But in many cases, the standard imaging that doctors have been trained to do doesn't find those rotational ligaments to be disrupted because they're not studying in that position. So one of the other areas that often leads to problems is in what we call the stylocervical region. And that's the styloid process comes off the base of the skull. The C1 transverse process comes off the side of the first vertebral body in the spine. And the nerves and the jugular vein run in the space in between. And this is a more normal configuration, showing that there's plenty of room in between these two structures for the jugular vein to drain blood out of the skull, and for the sympathetic superior cervical ganglion, the sympathetic nerves, to run up into the skull. But in hypermobile patients, this isn't a normal situation. Now, the autonomic component of this, the nerves that include the balance between the cranial parasympathetic nerves and the spinal sympathetic nerves, is essentially the yin and the yang of the balance of these two sympathetic parasympathetic that make up your global autonomic nervous system. So autonomic dysfunction means something is out of balance. It could be an over or underactive, depending upon whether it's an irritation or a compression causing dysfunction of any of these nerves. So this can result in a broad spectrum of these symptoms, including from repetitive stress injury on the sympathetics. You can get cranial nerve dysfunction from the impact of one nerve on other nerves. You can have gastrointestinal symptoms because the vagus nerve and the hypoglossal nerve tend to control some of the gastrointestinal function. It can cause auditory problems, including hearing, sounds that nobody else can hear. It can cause headaches from a number of different mechanisms, not the least of which is the back pressure of the venous blood not being able to leave the skull, as well as cardiac symptoms from the regulation of the heart rate being dysfunction either through sympathetic or parasympathetic imbalance. Now, jugular venous compression, we talked a little bit about that, can be both mechanical compression from those two stylocervical gap, and I'll show you what that looks like shortly. But it can also lead to stress, and just as a Chinese finger trap gets narrower when you stretch it, you can get stretching on any tubular elastic structure that you pull on, similar to stretching a water balloon, will cause it to get narrow. And then high brain pressure symptoms come from the backup, and that can cause all sorts of dysfunction, including real cognitive dysfunction, word finding difficulties, memory problems, as well as headaches and other forms of dysfunction. These tend to be in this condition something that does resolve with rest that takes the tension off of that vascular compression. But sometimes some of the symptoms are persistent. Now, the arterial system is also affected. And I've seen patients who have the carotid artery actually compressed and stretched by the head rotation out of place. But there's a well-documented syndrome called the bow hunter syndrome, which is from an archer pulling their head, and they turn their head 90 degrees to look down their arrow. And if you hold that position and you're hypermobile, you can actually occlude your vertebral artery. You can cause a stroke if you're not careful. So these are well documented conditions that have not previously been well associated with each other. And so patients tend to get gaslit if a doctor isn't thinking of putting this all together into one syndrome. Now, the symptoms that patients have, I find, are critical to understanding the patient's specific pathologic situation and the treatment strategy. And Dr. Sieferman mentioned a little bit about that. The way I think about it is the patients who have more problems in head going forward or backwards, it's more of a occiput to C1, the first motion segment problem being most dysfunctional. And they may have pretty normal C1-2 function, and therefore they have less rotational problems, or it may be the other way around. Or, like many of my patients, they have both. And sometimes we even see patients have more than one set of symptoms going into an operation. We only treat that one level, and then the other level becomes symptomatic from new stress being put on it. So it is important to tease out all of these factors and understand the whole spectrum of where are the greatest stress to the neurovascular system, and make sure that we're adequately and sufficiently planning a treatment strategy. And so one of the things that this looks like, here's an actual patient scan. And what we're seeing here is that first, there is often an anterior translation of the skull forward on the spine. And then there is rotation forward. There's a kyphosis. There is this increased atlantodental angle. Sorry, the clivoaxial angle where the head actually tips forward more than normal. And then that causes this styloid process to be tipped further down towards the C1 transverse process, which then occludes the veins, the jugular veins, blood trying to carry blood out of the head, so that the pressure backs up into the skull. So one of the unfortunate side effects is that patients tend to be hypermobile. They tend to be hypermobile in much of their body. And so there may be other hypermobile associated syndromes that may need to be teased out of the symptoms that are present from CCI, so that we're aware that treating the CCI individually may not treat these other symptoms to manage these expectations. And sometimes you treat the biggest problem, the other symptoms don't feel as bad. And sometimes you treat the biggest problem, and now the other symptoms become more affected because now you're more active, or you're doing things you weren't previously doing, and you're stressing the other system better. So we don't always know the ultimate impact of what we do, but we certainly are here. And as long as we understand what to expect when you're expecting treatment, we can go through this process together. And so there are many other issues. One of the things that I find, and I know many of my colleagues might see a diagnosis of fibromyalgia, psychiatric disorders, or functional disorders, and say, "Oh, I don't want to treat that patient. They're not going to get better." For me, it actually piques my curiosity because I know so many patients with EDS, CCI, and other conditions have been misdiagnosed with these buzzwords. And they do improve when you actually treat the underlying problem. And so this is another form of medical gaslighting. And so I do my best to actually dig in when others break them down. We look at, well, which symptoms are triggered by which movements, by association with other symptoms. When you get this, do you also get that? That tends to help us to link the two together and hope that treating one will make the other feel better. And then we separate out so that you know what to expect from the treatments and what not to expect. So the way I look at these things is I'll then dig deeper into, we'll order the necessary tests, and we'll be looking for what's going on with the jugular vein, what's going on with the styloid process, what's going on, in looking at it from different angles and understanding the proximity issues. Here's a patient whose styloid process is very close to their transverse process. Here's a patient whose head is tipped very far forward in that clivo-axial angle. From it, that asked me what I saw on that study that was read as normal. And what I saw was there was actually a very big gap between the C1 posterior arch and the back of the skull, the foramen magnum. When I see a really large gap here and a tip forward here, that to me says this is not a normal position, and this suggests hypermobility tipping too far forward. We also can see that this clivus tip here is very close to the dens. It's not supposed to actually be touching, nor is it really supposed to be sitting right over this front edge here. It really should be sitting more here and tipping up this way. So these are the things that I look for. This is the rotational CT. Many of my patients have wondered, why do you have to scan me looking left and looking right? Well, if one part of your spine is looking this way and another one is looking this way, you make the angle, you can see they really do make a difference. And so this is actually the front of this body. This is C2, and it's supposed to be, or it's oriented this way. And this is oriented. So that's a huge angle here. And that is very helpful because when we document the abnormalities, it makes it easier to convince an insurance company to pay for this. So the surgical treatment options, and this isn't a technical how to do this because I don't want any of you trying this at home, but we either fuse the relevant abnormal levels to stop the motion that's leading to the worsening of the symptoms. Another option is to go in and remove whatever the structures like the styloid process, the C1 transverse process, or the digastric muscle, which we'll get to in a sec, if those are contributing to the narrowing. And the third option is to stent or balloon the jugular vein open to give it a little bit more flow to prevent that vascular insufficiency that leads to the increased brain pressure that's intermittent. Having permanent occlusion of the jugular or partial occlusion of the jugular vein does lead to a different condition called idiopathic intracranial hypertension, which leads to very similar symptoms, but because it's unremitting, it can cause severe permanent nerve damage because of the permanent high pressure. That's obviously a much more serious condition. Not that hypermobility isn't serious. So, did you say fusion, Dr. Jenkins? That's a scary word. Why would you wave that word around? You seem like a nice guy. Why would you threaten to fuse my spine? I'm going to be like Frankenstein afterwards, right? Well, truly, we don't have another operation that makes the spine normal, stable. We only have the ability to provide complete stability at one or more levels. And so we try to judiciously use that of one or two, the most affected levels of the 8 motion segments in the cervical spine. So we're not taking away all your range of motion. We're only taking away the top 2 of 8, leaving you the other 6 to do with whatever you're doing. And the odds are, if you are hypermobile to begin with, you're already moving more than everybody else in your peer group. And so even taking away some of your range of motion, you still have pretty normal range of motion afterwards. And then generally this follows the ancient medical adage, if it hurts when you do that, don't do that. So if it hurts when the top 2 levels are moving, stop them from moving. There may be consequences to doing these. Some patients do develop additional stress on the adjacent levels, but I would rather do that and deal with those down the road than make you continue to be miserable and untreated in the meantime. So this is what this looks like radiographically. The top one is just the top level, screws in C1, screws on the skull plate. Second one is screws into C1, screws into C2. And then the third one is screws into C2 and a cable at C1. And so these are each tailored to the individual patient and what we think is the least invasive but most effective way of having an impact on your quality of life. The other treatment, as we mentioned, one of the other treatments is resection, where we come in from the front to actually remove the styloid process, and if necessary, the digastric muscle, which if it goes across the jugular vein and the nerves in this area, causing increased pressure in the region, we could take that. It's considered a minor muscle of chewing, not a major one. So taking it doesn't cause any permanent damage. Um, and then the third way that we approach this, and from some of the people I've spoken to, this is really best done after we've done one or two or both of the other two, and then treating any residual jugular venous stenosis either by putting a balloon through, from outside the body and snaking it up into this space, ballooning it open if there's scar that's holding the jugular vein to not be able to fully re-expand, which happens sometimes, or putting a stent across it to hold it open, if you think that maybe the hypermobility has led to weak enough soft tissue that there isn't enough inherent tension to hold it open. So fundamentally, surgical stabilization, the fusion procedures that I do, tend to improve patients' symptoms. So far, all of our patients have had some improvement in their symptoms, and in many cases have been able to get back to more meaningful lives. But there are different approaches to how people do that, and some of that is still the art of the practice of medicine, even among EDS knowledgeable and experienced doctors. We sometimes disagree on the perfect way of approaching every single patient. And that may be because of specifics of our personal experience and what we think works. But this is a review of some of our research. This is a little bit more of what you'd see in a typical medical presentation. And you can see that we do see that all of our patients do see improvement, not just in their head and neck pain, but sometimes in their back and leg and arm pain as well. So there is value to treating the neck first. And don't be afraid to ask for help. There are entire Facebook communities for support. The biggest one has 41,000 members, but they are literally hundreds of Facebook communities for people suffering from EDS. And you may find one that appeals to you in particular, or you may join several of them. And I suspect that some of these have multiple members. One of the problems I've struggled with, and I'm sure Jason can talk about this, and I'm sure he and his people and Melanie and her people have also struggled with this, is insurance doesn't really recognize this entire entity. The dysautonomia, it's very hard to convince them, and that's why we need to go to the trouble of doing all the tests that we do and getting all the documentation and fighting and fighting and fighting. So you do need help. Sometimes they'll pay, but most of the time they'll say no. Because let's face it, right now insurance companies are not in the business of providing care. They're in the business of collecting premiums and denying care. In fact, BlackRock, a big major investment firm, owns 10% of United Healthcare. They are suing United's CEO because after one of their other CEOs got shot, they started paying out premiums and their profitability went down a little bit, or paying out claims, because I think they were afraid. But he sued them saying, "You've got to stop. We want more profit. We don't care about patients. We want profit." And I think that's just, I mean, it's one thing to think it, it's another thing to actually file court papers demanding it. So this is a real problem, and it requires, like I said before, be patient, be persistent, be pragmatic, understand what you can get and get it to help. You don't expect cure, but do expect help is on the way, and don't give up. And that surgical treatment can be beneficial if you've run out of the options that Dr. Seiferman and Inspira can provide for you. So I want to thank you all for your patience, including the patience with the technical issues that we've had here today. I'm certainly disappointed that you didn't get to hear from the patient herself what an impact surgery can have if you get that far down the road. But if you have any other questions, please feel to reach out. On the left side of the screen is a link to my YouTube channel where I have a couple of other videos similar on this particular subject of craniocervical instability. On the right side is for my website in general. And if you want to just grab a screenshot and save these social media tags and my website to type it into your search bar, it's just jenkinsneurospine.com. But we get it. This is not an easy problem, but that doesn't mean you're not worth finding a solution. So